All right, we're going to get started. First, I just want to say welcome, everyone. Welcome to the second webinar in the ARDRAW Cohort 4 webinar presentation series. Today, we have with us 3 of our students from Cohort 4 who are going to be presenting on the research and the findings of all the research that they've done over the past year. But before we do that, I just want to introduce the ARDRAW team. So my name is Erica Smitka, and I'm the program coordinator at PRI, and I work with our colleagues over at SSA. So I'll send it to Laura to introduce herself.
Hello, I'm glad to see that we've got several people joining us today. My name is Laura King. I am the project officer at SSA, and I just want to welcome everyone. I will pass it over to my colleague, Kristen Harper. Kristen, are you on the line? I'm not hearing her, so I guess I will pass it back to Erica.
Thanks, Laura. And I should say from PRI, we also have Margaret Lassiter on the phone. So welcome to all, welcome to everyone. I think that most of you are pretty familiar with the ARDRAW program, but if you are not, the program helps to fund PhD and master's students to expand work and research in the field of disability studies. So we've been really fortunate to work with these 3 students that we have to present here to you today. And I'm excited to hear more about the work that they've done. So without further ado, I'll pass it over to Dalton. Dalton Stevens is our first presenter. He's a PhD candidate in the Department of Sociology at the Maxwell School of Citizenship and Public Affairs at Syracuse University. Dalton.
Hi, can you all hear me and see my slides? Okay, great. Yeah, I'm Dalton Stevens. Thanks for the introduction. I guess I don't need to do that. I want to thank PRI, ARDRAW, and my mentor, Professor Harrington Meyer, for all the support over the last year while I've been doing this research. Today, I'm going to be presenting my research. It's a supplemental paper for my dissertation that I did for ARDRAW, and it addresses the question. It has a much more concise name than I had originally submitted, Erica. How do young adults with disabilities rebalance self-reliance, family-reliance, and state-reliance? And there we go. Just to give you some background, there are 52 million millennials that have or had disabilities by the time they graduated high school. Now this group is between 25 and 40 years old, and they're beyond high school. They're beyond that support cliff that we often talk about when we talk about disability services across the life course. Millennials with disabilities have made fewer social transitions on average in education, employment, and independent living than their peers without disabilities. But there are many millennials with disabilities that have made these social transitions, thanks to some families and some policy interventions that have really paved the way to education, employment, independent living, and new care arrangements. Among policy interventions, cash benefits from SSA, healthcare access and daily supports from Medicaid, tuition support from vocational rehabilitation, and also vocational training are important to these social transitions among young adults with disabilities. However, we know precious little about how young adults with disabilities actually arrange the support that they receive, and this gap in the literature really motivates my research. To give you a theoretical overview, because my project centers on how young adults with disabilities engage with family and state support during life course transitions, life course theory provides a strong framework for my project. The core claim of life course theory, of course, is that structural context, timing of transitions, social relationships, and human agency and development determine life course outcomes. This is apt for a study investigating how support influences education, employment, independent living, and care outcomes for young adults with disabilities. Key concepts I want to just briefly define are transition. So this is any kind of change in role or status across the life course. Agency is the ability to affect change, to help determine your future outcomes. Of course, no one has complete control over what's going to happen, but it's the things that we do to try to shape them. Social relationships or linked lives in life course theory are the interpersonal connections that range from intimate relationships to acquaintances. I focus here on families, including husbands, wives, partners, parents, children, and cousins, even grandparents. And then lastly, social structure. Simply, it's just pattern social relationships that happen through social organization and practice. Here I focus on policies that regulate and inform how young adults with disabilities pursue their goals in education, employment, independent living, and care. And I focus on Social Security policy, Medicaid, and vocational rehabilitation. Just to give you a quick rundown on my methods, I conducted 28 life history interviews with young adults ages 25 to 36 with various disabilities that were diagnosed before age 18. I did that to have that continuity of disability from adolescence and high school through the transition. It's a unique population that you typically has more need in terms of services. Life history interviews are a good tool for gathering in-depth data on long-term transitions, things that aren't readily observed with ethnographic observations and are difficult to assess with quantitative methods that are typically a snapshot at one time. So life history interviews provide us with insight to how people navigate barriers and supports and how they make decisions in the sequence of events that lead to certain life course outcomes. I recruited participants nationally using, a very focused strategy targeting disability groups, organizations, pages, and using my own personal disability contacts. All research materials were in plain English with icons to facilitate understanding for those with reading difficulties. I used a very flexible design in my research to accommodate all types of disabilities, including things like dyadic interviewing, which is involving someone other than the participant in the interview for support for the participant. And I will flag that data. I don't think it comes up in today's talk though. But yeah, it was a very flexible design so that I could include as many people with disabilities as possible. In terms of disability, most participants reported multiple types of disabilities, not just one. 86% reported 2 or more disabilities. The single most prevalent type of disability represented in my sample are mental health disabilities, followed by physical disabilities. Most of my participants also, just to break it down, 82% were employed, most were employed, most were living on their own in homes that they either owned or rented. To talk about a little bit about SSA programs and other social assistance programs, 16 out of my 28 participants received benefits at the time of the interview or had during the transition to adulthood. And this descriptive statistics table just kind of breaks that down on who was currently receiving and who had previously received support from various programs, SSI, SSDI, Medicaid, Medicare, SNAP, and TNF. I use an iterative grounded theory approach to analyze my narrative qualitative data. Iterative simply means I used an inductive, ground up from the data, and deductive, top down from theory approach during analysis, moving between those two levels of analysis. This approach begins, and I began with open coding to become familiar with the data and close with the cases to develop codes that you then shift to focus coding and developing themes by moving across cases to map the convergences and divergences between experiences. From those codes, I started developing themes through memoing. As I was developing memos, that's how I came upon this analysis. And then I began this process of abduction to fit my data with existing policies and theories. And that's really the step that translates qualitative work from real life experiences into relevant and usable knowledge. And I use life course theory and policies that participants referred to specifically in their life histories as my starting point. Today, I'm presenting an analysis that's focused on the variation that I observed in how young adults with disabilities rebalance support from families and the state while pursuing independence in adulthood. Specifically, they were pursuing, in this analysis, education, employment, independent living, and new care arrangements. Importantly, these steps in a different piece of my analysis comprise the axis of inequality, or this axis of independence. And what that suggests is that these people are pursuing independence along these different pathways involving education, employment, independent living, and care work to develop more autonomy in their daily lives. So that brings me to the question and the findings. How do young adults with disabilities rearrange or arrange self-reliance, family-reliance, and state-reliance? And I find that they do so in 4 ways. Some wanted to enhance self-reliance by shifting support from family-reliance to state-reliance. Some wanted to end state-reliance altogether and maximize their self-reliance. Others wanted to balance self-reliance, family-reliance, and state-reliance while maintaining their goal pursuits. And others yet leveraged self-reliance and family-reliance, some with no desire for state support, but some who really could have used support at key moments during transition. In the first group, those who wanted to obtain support from the state did so in order to rely on their families less. Ernie, for example, is a 32-year-old non-binary autistic person, that's their preferred language, also diagnosed with mental health, intellectual, and health disabilities, had lived away from their parents since high school. They went to a residential high school for autistic children. And when I interviewed Ernie, they had just completed a master's degree and started working on the campus that they got the degree from. But Ernie was struggling to coordinate care because they couldn't access support through Medicaid. Ernie's application was rejected twice. Ernie really lamented this. They said the support staff that he informally paid, do it under the table. So not technically, I can't get it because this state doesn't allow you, at least the providers around here don't, unless you go through the front door, which means you have to get Medicaid and they won't let me get Medicaid. It's very frustrating. Like, I'd pay for my things. I don't know. They say I have too much money and I don't qualify. Well, first they said I wasn't disabled enough. And this time they rejected it again because and I think it was about the money. So in the next example I have of people who wanted to really shift self-reliance from family, to enhance their self-reliance by shifting the support from families to the state, comes from Emma. And she's a 25-year-old woman diagnosed with several disabilities. And others like her had to stop and start receiving benefits several times during the transition to adulthood. Keep in mind, she's 25 years old and she's already been on and off programs multiple times. And when I asked her about organizing this, she brought up shifting care needs from her family, from her husband's insurance to the state in order to maintain her life. She said, I have to really think ahead on that. Like, I'm married, but in terms of insurance, I did not let my husband sign my son's birth certificate because I knew that means he wouldn't be able to get health insurance. My husband doesn't make that much. I don't make that much. Me as an individual can qualify. Us together can't. So we would have to go through his job for insurance, and Volvo insurance, it's super, super expensive, a very high deductible. And she goes on to explain that the insurance available through her husband's employer was expensive, covered fewer disability-related services, and they would have trouble paying for medications. The support really helped with daily services and medication, things that she and her husband couldn't afford, in conjunction with maintaining work and meeting disability needs of not only Emma, but Emma's children. And they found this support to actually increase their reliance and their self-reliance and achieving their goals for adulthood. Other participants were in the second group who wanted to end state reliance to really maximize self-reliance instead of just enhancing it. And Bailey is a 25-year-old woman who's diagnosed with several disabilities, most notably osteogenesis imperfecta, and she used a wheelchair for mobility. She told me with some trepidation, I feel like this sounds really bad, and I would not say this in front of a lot of my friends with disabilities, but I want to get off Social Security. I don't want to have to live on $2,000 a month. That's not sustainable for anybody, but that's a whole other topic. But if I can make enough money to support myself and live as independently as I'll be able to, whatever that looks like, I will be a happy camper. Of course, Bailey is very realistic. She recognizes that the life-saving equipment that she uses on a routine daily basis keeps her alive, and it's going to take some time to get there, but her ultimate goal is to stop receiving benefits and to increase her ability to take care of herself financially. Similarly, Patricia, a 36-year-old woman diagnosed with several mental health disabilities, also wanted to stop receiving benefits and pursued education and employment without her father's knowledge because he was worried about her losing cash benefits from SSI. I asked Patricia really to contextualize this quote, I asked her how she had convinced her father to let her go to college and get a job. And she said she didn't. She lied. She basically did it without his knowledge. And then when she got into college, she explained that what was happening. And then she continued on about work. I sort of did the same thing with working because he's not really as excited about me working as I am because of the whole thing with the government, because he doesn't want me to lose my money. I feel for that too, but I feel like I need to contribute in some kind of way. I need to feel normal in some kind of way. Patricia recognizes that she benefits from having SSI, but it's not her ultimate goal. Again, she's one of these that wanted to end state reliance and maximize independence. So other participants wanted to, maintain or balance self-reliance, family-reliance, and state-reliance while they maintain goals they had already achieved, things like living on their own, their jobs, their new care arrangements, or while they're pursuing goals like education. All of these participants actually found creative strategies to maintain their eligibility. For example, Paul is a 33-year-old man with muscular dystrophy. He said, obviously, just given my disability and being on benefits and kind of like so much of that you have to figure out with your family. You're not able to be as independent with it, finances as you'd like, just because of how things are. And like not wanting to jeopardize my benefits, so depending on others more financially than I would have preferred. The interesting thing about Paul's case is that he is a lawyer and he owns his own law firm. Therefore, he gets to set his own pay scale, and he pays himself just under the amounts in his state so that he can continue receiving Medicaid and SSI to guarantee his benefits. He qualifies for Medicaid through SSI. He tried to figure out Ticket to Work, but he and his parents couldn't figure out how to meet the personalized threshold annually, and he abandoned that idea very quickly. Kenny, a 33-year-old man with quadriplegia from a spinal cord injury from when he was a kid, he wanted to continue living in the house that he had bought with his best friend and their shared team of care workers while he was pursuing a bachelor's degree. It was the fourth time he had retried getting a bachelor's degree, and he explained why he only kind of works while he's going to school. I'm too scared of losing financial incentives like Medicaid. If I lose Medicaid, I lose in-home services and I lose my ability to live independently. Fortunately, Kenny found a program, the 250% disabled workers program, that increased his eligibility to 250% of the federal poverty line, and he gets that by recycling $5 worth of cans a month. Those who never used and didn't report wanting to use social assistance programs, so those who leveraged self-reliance and family-reliance, these participants often had parents who paved the way to college financially and with loads of encouragement. Following college graduations, many of these participants found careers and experienced less instability in their arrangements. And one example, Flo, her father actually moved to the city that her graduate institution was in, bought a house, and they lived in the house together with a series of boarders while she finished her degree. Afterwards, her father, in this quote, decided to pay off her student loans so that she wouldn't be burdened by the interest rates. On the other hand, people like Heather, another well-resourced participant, experienced similar support, but found that support was precarious, especially as it intersected with developing identities during adulthood. When Heather came out to her parents in 2014 as lesbian, she was afraid that her parents were going to stop paying her tuition. Fortunately, she was able to locate a program on Yale's campus that would have came in and helped her out had she lost that support from her parents, but she didn't, fortunately. So altogether, I want to wrap up. I've showed just 4 ways that my participants rebalance self-reliance, family-reliance, and state-reliance to really better understand how young adults with disabilities access and obtain the support they need while pursuing education, employment, independent living, and new care arrangements outside of their families. The findings really shed light on some policy shortcomings that limited young adults' pursuits in these areas. The experiences of participants who wanted to obtain SSI, Medicaid or vocational rehabilitation, the restrictive eligibility criteria really prevented them from relying less on their families and developing in their own autonomy. Those who wanted to leave programs behind identified problems with affordable disability services beyond Medicaid, and others cited that the modest benefits from Social Security would never allow them to pay for their care as quickly as, even though they wanted to transition off benefits as quickly as possible. Others were afraid to work, because they feared it would jeopardize their benefits. And many of those participants had difficulty understanding Ticket to Work and work incentive programs because of the additional criteria and reporting those programs required. Lana was the only participant who was able to leave SSI and Medicaid during transition in my study, and only did so by accessing a very narrow pathway for young adults with disabilities. She was able to obtain scholarships and gain admission to a private selective university that paved her path to a successful accounting career. And alternatively, people who didn't have that kind of support, sought tuition support through vocational rehabilitation, which once again added more administrative burden. So to wrap up, I think I've went over it by a minute and a half, but considering that juggling state support was one of the biggest barriers to goal pursuits because of the amount of administrative burden, means testing, and over complexity, I suggest addressing the fissure that exists between these policies in SSA, Medicaid, and vocational rehabilitation that limit communication and coordination between agencies. Programs may be able to address these issues by consolidating an eligibility criteria across the program that would include more young adults with disability diagnoses, coordinating services across the programs and care, education, employment, independent living, think along that structure, and then revising the SSI pathway to Medicaid. I thank you so much for your time today. I look forward to all your questions about my research and all your comments. Thank you so much.
Thank you so much, Dalton. That was great. So some housekeeping things that I forgot to mention at the beginning. If you do have any questions for our presenters, feel free to either unmute yourself or you can enter it right in the chat there. And while someone's presenting, you can also use speaker view just so that they're more highlighted than the rest of us. And then the last housekeeping item before we get to questions is that this presentation will be recorded and will be available on the ARDRAW website within a week from tonight. So questions for Dalton?
I have one question. Can you hear me?
Yep,
Go
ahead.
Hi. I missed your descriptive stats. You said that 16 out of the 28 was receiving SSI.
So yeah, 16 out of the 28 had received SSI, SSDI, Medicaid, Medicare, and or TANF. So out of the descriptive statistics slide, so at present, about 20%. So I think it was 11 at the time of the interview were receiving supplemental security income from Social Security Administration. And then only, so just under 15% were receiving SSDI out of 28.
Okay, yeah, I thought I saw 18%. I wasn't sure. So the 16 is like a total of all the benefits?
That's the cumulative, yeah.
Okay, got it. Thank you.
Yep. Thank you for your question. I'm happy to clarify.
And I have another question for you. Did you see any demographic similarities between the type of supports that your interviewees most used or thought were most helpful?
That's a really good question. It depends. Yes. So people who needed daily physical support, in terms of ADLs, IADLs, that kind of demographic descriptor of the sample, were the most likely to need Medicaid, specifically for HCBS and long-term services and supports. But within that group, who were, for example, receiving Medicaid or pursued that kind of support, also had problems with medication or just physical health problems that limited daily activities. So it wasn't just people with, for example, say cerebral palsy, which I had, about a quarter of my sample had that diagnosis. But it included a lot of people with mental illnesses and physical disabilities right there. In terms of SSI, it was definitely those who were more severely impacted by impairments associated with disability. Yeah.
Thanks, Dalton.
Yeah.
Other questions for Dalton?
Hi, Dalton. I don't have a question, but I do have a comment. I just wanted to say really good job with the presentation. I really liked how you broke it down between the state reliance and family reliance and individual reliance. I think those are three very important types of reliance that people with disabilities count on, and just breaking it down that way was very helpful. And I think it really nicely ties into something that my study goes into as well. So I really appreciate that, because mine's a cross-sectional study. So your qualitative feedback really kind of accentuates, or probably would mirror if had I gone down that route. So I really appreciate it. Thank you.
Yeah, you're very welcome. I'm happy to do it. I can't wait to see your research. Thanks for the kindness. And with identifying the self-reliance, I'm really trying to develop that theory of agency within sociological literatures, because often people with disabilities are excluded from being agentic. So I feel like showing how they actually take part in arranging the supports that they do have really centers on that self-authorship and that self-direction that I think is missing from a lot of studies. So thanks for recognizing that nuance. I can't wait to see your research either, Rumi.
Thanks so much, Rumi. All right, so if anybody does have a question that pops up for Dalton, feel free to either reach out to him via the ARDRAW email, or you can hang on and ask a question at the end. But for now, we'll move on to our next presenter. Our next presenter is Kasim Ortiz. Kasim is a PhD candidate in the Department of Sociology and Criminology at the University of New Mexico. Kasim?
Good afternoon. All right. Just to make sure, are you seeing the full PowerPoint?
Yes, not in presentation mode yet, but.
Okay, that's what I was trying to make sure. Good afternoon. My presentation is titled Uncovering Invisible Intersectional Vulnerabilities at the Nexus of Opioid Use, Employment, Disability, and Sexual Orientation. I don't have to do an introduction of myself either. That was already done. So I will, the presentation will cover background, theoretical considerations, the current investigation and research questions, data, methods, analysis, results, limitations, and policy implications. Background: between 1999 and 2018, 446,032 individuals died in the US involving opioids. There were gender differences in the rate of percentage of drug-related deaths during that time as well, where there were increases for men from 8.2% to 27.8%, and among women, there were increases as well from 3.9% to 13.6%. However, there were differential rates of drug-related deaths across different types of socioeconomic strata, whether that be low income or those with lower educational attainment. In research looking at Social Security disability recipients, there were increases in rates of opioid use, particularly for those aged 40 to 49 among women and people with some college or lower educational attainment. Overall, increases in opioid use across this time period, as well as increases in deaths involving opioids, has contributed negatively to economic impacts. Whereas in 2017, $1.07 billion were lost on the U.S. economy via reduced quality of life and value of life loss. However, in much of the research assessing opioid-related deaths, there's been two populations that have been less examined, particularly sexual minority individuals. And sexual minorities are those that identify as lesbian, gay, or bisexual, or intersex, or non-heterosexual. However, interesting, among sexual minority adults, there have been increases in rates of opioid use compared to their heterosexual counterparts. Also, sexual minority adults exhibit heightened rates of disability. Sexual minority adults also experience worse indicators of economic prosperity, whether that's higher unemployment, lower wages, or higher rates of poverty. Researchers have pointed towards sexual minority stress as a theoretical conception to explain such inequities. And basically, this theory argues that discriminatory environments fueled social disadvantages and shaped the health behaviors and well-being of sexual minority populations, where they exhibit worse health behaviors, outcomes, and a host of measures of well-being. Yet, if we think about sexual minorities as a homogeneous population, we miss very critical population-level health indicators. For example, bisexual health paradox. Across a wide spectrum of health indicators, bisexual individuals often exhibit worse health outcomes compared to their lesbian and gay counterparts, as well as their heterosexual counterparts. Also, when we think of sexual minority populations, if we don't attend to racial and ethnic variations in health and social outcomes, we miss important and key critical variations among the population. Therefore, my research has utilized intersectionality as a conceptual framework to understand why we may see gender differences within looking at variations across sexual orientation and employment disability status as it relates to opioid use behaviors. Intersectionality is a conceptual as well as methodological and praxis framework that looks at overlapping systems of oppression that contribute to health equities in non-additive ways. In particular, for this research, I drew from economic sociology in the work of McCall, who argued that there were three types of intersectional quantitative research: intercategorical, intercategorical, and intracategorical. It's important to know that in medical sociological research, often most research utilizes individual level indicators of social positions as markers for systems of oppression. In intercategorical intersectionality research starts with the premise that categories are often messy and not conducive to describe social realities. Intercategorical looks at the differences across different categories, and this is the one that's primarily used in population level research. And intracategorical looks at within group variations in terms of how systems of oppression shape social realities and admirative outcomes. Within medical sociological research, most research has looked at race, class, and gender, the intersections of race, class, and gender as markers of racism, patriarchy, and classism. However, less research has looked at heteronormativity and ableism. Recently, Malden and Brown argue that disability research within medical sociological research requires greater attention. They argue two main points. First, that disability is often used as a medical classification versus a proxy of social location indicating inequality. Also, Malden and Brown argue that the connections between intersectionality and disability research are quite primed to enhance medical sociological research. Particularly, they argue that the focus of intersectionality on producing policy-relevant answers in terms of health inequities are aligned with disability research, as well as the ability for intersectionality research to implicate social inequality also merges its emphasis within disability studies. Again, they argue that utilizing individual level markers of social location, we should keep our focus on structural realities, in particular, in this case, the consequences of ableism's impact on shaping health inequities. So the current investigation and research questions. My research project looked at differences in opioid use across sexual orientation statuses and employment disability statuses. So the first research question was, are trends in opioid misuse decreasing annually when considering sexual orientation and employment disability statuses? And two patterns of opioid misuse follow a gradient when considering the intersection of employment and sexual orientation. The third research question was, are there pronounced gender differences in opioid misuse at the nexus of sexual orientation and employment statuses? And then the fourth research question, when looking at those indicating unemployment because of a disability, are there differences in opioid use across sexual orientation statuses? To answer these questions, I utilize cross-sectional repeated data from the National Survey of Drug Use and Health, which is a multi-method data collection and includes a multi-stage probability sampling frame across all 50 states and the District of Columbia. It's nationally representative of the non-institutional population age 12 and older. Across 2015 and 2019, there was a 79% to 84% weighted interview response rate. And for my particular analysis, I utilize adults age 18 to 64. I call them working age adults. And that included N of 155,718 working age adults, which was inclusive of 7,099 working age adults indicating being disabled and unable to work. For my outcome measure, I used a binary measure of opioid misuse, which was self-reported, and the binary measure meets the classification for DSM-4. The predictors, the primary predictors were sexual orientation, which was based off of a question that asked, how do you identify? And it included heterosexuals, lesbian and gay, and bisexual respondents. I also constrained my sample to 18 and older because in the National Survey of Drug Use and Health, only adults are asked the question about sexual orientation. And to capture work disability, I utilized a question that asked, in the past 2 weeks, were you looking for work, laid off and not looking for work, going to school, training full-time, keeping house or caring for children full-time, retired or disabled? The disabled category is how I was able to identify those that I considered work disabled. And then I combined the sexual orientation and work disability measure to produce 9 categories. And I will get to why I did that a little bit in the next slide, but these were the categories. The reference category were those that identified as heterosexual and were employed. And then it's heterosexual unemployed, heterosexual work disabled, and lesbian gay. Same 3 categories were repeated for lesbian, gay, and bisexual respondents. Now, I combine those measures for a couple of reasons. First, statistical power when conducting tons of interactions, as those categories plus stratifying by gender diluted a lot of the power that I was able to detect significance. And you will see when I present the results that some of the significance were already marginal. And so combining those measures is a way to minimize and recapture some of that power that's needed for statistical detection of significance. Covariates that were included in my models were age, race, ethnicity, gender, marital status, educational attainment, family household income, receipt of government support, not including SSDI or SSI, children in the household, self-rated health, health insurance status, past year psychological distress, and past year alcohol dependence. All of these covariates were selected because previous literature indicated that these were potential confounding measures in the relationship between opioid misuse and sexual orientation and or work, employment, and disability status. So my analytic strategy was threefold. First, I conducted descriptives on categorical variables where I looked at opioid use compared to those that indicated they did not have past year opioid misuse. And then all of my measures, including the predictor measures, the combined measure, as well as the covariates. And then I computed in-year rates of opioid misuse using binary logit models and assess whether the relationships for, the rates across each year were either linear, quadratic, or cubic. In those tests, it identified that all of the measures were linear. There were no quadratic or cubic rate increases or decreases. And then I used a pool binary logit model, which was the full data across all years to assess the relationship between sexual orientation, employment, disability status, and opioid misuse. In the descriptive statistics, all categorical variables were statistically significant, so I'm not going to present those because it's a long table, which just indicates that there were differences between those that self-reported that they utilized opioids in the past year versus those that did not use opioid in the past year against all of the categorical variables. So here are the binary logit models that I calculated to produce the rate percentages, and I calculated absolute change as well as relative change. The absolute change are going to indicate across all years, starting in 2015 and ending in 2019, what were the percentage change. And then the relative change are the same rates across the differences in the rates across each year multiplied by 100. And so what we see here is, I cannot see, hi, thank you. What we see here is that among those that identified as unemployed, there were statistically significant decreases that were heterosexual unemployed. There were statistically significant decreases across the study period of 3.58%. And of those that were also unemployed in heterosexual, there were also decreases. And looking at those that were lesbian, gay, and work disabled, we see that there were decreases, although it was marginally statistically significant, of 0.13%. And then those that were bisexual, unemployed, also indicated a decrease in opioid use across the study period of 0.15%. It's important to denote that I utilized the most recent data in 2019. However, there's data indicating that in 2020, there were increases in opioid use, so that's important to keep context. All right, and here is my full model, which included all respondents across all years. And these models are all fully adjusted. And again, I conducted gender stratified models because several reasons. One, consistent research indicates that there are gender differences in opioid use behaviors, as well as when we look at sexual orientation, there are distinct differences in terms of disability rates, as well as opioid use rates among sexual minorities based on gender. And in the full sample, in the fully adjusted model, what this indicates is that lesbian and gay individuals indicated a statistically significant increase in past year opioid misuse compared to their heterosexual employed counterparts, as well as those that were unemployed, lesbian and gay individuals who were unemployed. And the most interesting comes when we look at bisexual individuals. So bisexuals who are employed indicated an increased rate of past year opioid use compared to heterosexuals who were employed, as well as those that were unemployed and work disabled. And as you can see, there is a gradient here in terms of rates, where those that were bisexual and unemployed had a higher rate, but those rates seem to increase across those categories, where those that were bisexual and work disabled exhibited the highest rate of past year opioid use, not looking at gender differences. And then among men only, we see that the only category that was statistically significant were those that were gay employed, which is a very interesting finding, that they were the only group that exhibited statistically significant increase in past year opioid use compared to their heterosexual male counterparts who were employed. And then when we turn to the model that looks at women only, we see again that there is some unique patterning. So lesbians who were unemployed exhibited a statistically significant increase in past year opioid use compared to their heterosexual women counterparts. However, when we look at those that were lesbian who were unemployed, that seemed to increase even higher. However, when we looked at those that were lesbian and identified as work disabled, there was an increase in terms of their heterosexual women counterparts, but it was much lower than those that were lesbians who were employed or unemployed. And a similar pattern is identified when we look at those that were bisexual women that were employed, unemployed, and work disabled. Work disabled, bisexual women who were work disabled indicated statistically significantly increased rate of past year opioid use compared to their heterosexual women employed counterparts, but it is lower than those that were unemployed, only unemployed. So for time's sake, I know that I'm running over. I am going to skip this. This is just the same patterns that I just identified. There are some limitations that are noteworthy. First, this is the sample of my analysis were those that were non-institutionalized, and that can present problems because we know that those that experience causal contact have higher rates of unemployment as well as disability. And we know that sexual minorities exhibit higher rates of causal contact as well as disability unemployment. So that might amplify some of the results where sexual minorities would exhibit even higher rates of past year opioid use when considering potential causal contact. All of the measures are self-reported, and there were no direct administrative data to capture whether the recipients were actually SSDI or SSI recipients. And temporal patterning of questions. So the employment question asked in the past 2 weeks where opioid misuse captured past year. Although previous research has indicated in the general population that such temporal patterning when looking at opioid use did not introduce bias that nullified the results. Policy implications. So there's a need to collect and capture sexual orientation and gender identity status and administrative SSA data in other population level survey programs. For example, the Natural Beneficiary Survey could be one opportunity to do so, as well as utilizing machine learning algorithms to specify sexual minorities and gender minorities status in mortality files. Also, I didn't present this, but those that were aged 35 to 49 exhibited heightened risk of work disability as well as higher rates of opioid use. And I overlaid this with sexual orientation, and that was similarly the case. What that indicates is that those that are aging are using opioids at higher rates, as well as experiencing work disability at higher rates compared to their younger counterparts, therefore indicating a greater need for potential programmatic support through entities like SSA. Also, there's a need to look at structural state-level discriminatory environments as a potential to amplify inequities identified in the current study. For example, there's been research that indicate that sexual minorities residing in states with higher discriminatory policy environments, which most of the research looked at marriage inequality. However, there's research looking at other dynamics that demonstrate this as well, that they have poor health outcomes compared to their sexual minority counterparts in states with less discriminatory policy environments. So that's a policy implication that future research should try to disentangle. And that concludes my presentation. And if I went through that, sorry if I went through that really fast. The Puerto Rican in me sometimes gets the better of me. So I was trying to make sure I was not going too fast, but I was running up against time. So
No, that was perfect. You were good. So I think we have is that a question, or it might be just clapping from Catalina. But any questions for Kasim? You can either type it in the chat or just unmute yourself.
well, I muted myself. Thank you for attending the presentation. And if you have any questions, please feel free to email me.
Thanks. One quick question, actually. So where do you see yourself going with this research next? Where do you want to?
Yeah, so one of the things that I have been working on is so the mortality. So in the policy implications where I discussed utilizing machine learning algorithms to identify sexual minority populations using mortality data, that's where I'm going. So two things. One, I want to figure out how I can advocate to get sexual orientation and gender identity added to the National Beneficiary Survey as one opportunity, but also the nerd in me and the statistician in me is pursuing developing algorithms to identify sexual minorities utilizing administrative data. And I think that can make a lot of inroads. And I know one way to capture gender minority individuals is to use gender dysphoria as a medical classification as one potential way to do that. But in terms of sexual orientation, it's a little bit trickier. And so I'm working on I'm actually conducting a systematic review now on that literature to figure out what are the best ways to proceed. And then I plan on empirically trying to do so.
Well, that sounds really interesting. We'll definitely keep my eye open for it. As Kasim said, if there's any other questions, feel free to email him or you can type it in the chat and ask it a little bit later. All right, so we'll move on to our next presentation here. Our next presenter is Dr. Rumi Agarwal. Rumi recently received her PhD and is now a Simmons and Hernandez Suarez postdoctoral fellow at Florida International University. Rumi.
Thank you so much, Erica, for that introduction. I will share my screen. Oh, sorry. All right, can everyone see my screen?
Yes.
All right, perfect. Hi, everyone. Thanks for being here. My study is titled Financial Planning and Utilization Among Parents of Children with Intellectual and Developmental Disabilities. It is an exploratory study which I conducted with my mentor, Dr. Shauna Burke. So let me start with giving you a little bit of background about my study. So we know that families of children with disabilities experience significant amounts of financial distress, and 26% of working age adults with disabilities are currently living in poverty. Now, we know that this impacts life outcomes like decisions that we make for health, education, employment, and independent living choices. Studies have found that if you engage in financial planning and utilization of accounts like checking, savings accounts, or investments accounts, they can improve outcomes for these families and their children. Unfortunately, utilization rates among this population is low. 18% in 2017 did not have a bank account, and 60% were not saving for emergencies. A significant amount of the barriers that have been noted is that planning activities have been largely aspirational among these families, and they also worry about their competence in making financial decisions, about not having enough money itself, and also worries about losing government benefits. Now, like Dalton said in his research about state reliance and self-reliance, a lot of you may know that to qualify for a lot of the government benefits, there is a threshold of assets of up to $2,000. I'm sorry, up to a certain threshold. And because of that, it kind of like leads to a spiraling effect of poverty where people are not able to accumulate wealth and leap out of this poverty that they are in. To kind of counter that, the Achieving a Better Life Experience, or the ABLE program, was enacted in 2014 for people with disabilities to kind of offset that challenge between self-reliance and state-reliance. And so for people with disabilities before the onset of the age of 26, they would be able to put money aside in a savings or tax investment account that had tax advantages. It would not affect government benefits to a certain limit, and they could use the money in this account for a wide variety of disability-related expenses, such as health, education, and employment. Now, each state in the US has its own ABLE plan. And so for Florida, the annual contribution that friends, family, and the individual with the disability can make is $15,000, with a maximum contribution of $418,000. Now, interestingly, in 2019, data showed that less than 1% of eligible individuals in the United States actually had an ABLE account. So understanding and recognizing the fact that tools and accounts like the ABLE exist to help overcome the choice between state reliance and self-reliance, I began to look at the literature, and I realized that there was a big gap in trying to understand what specifically was the financial planning and utilization behaviors among families of children with intellectual and developmental disabilities. And even more specifically, I wanted to look at the ABLE program to understand why such a novel idea of an ABLE account was still being so underutilized by families of children with disabilities. So my research questions were specifically, what is the awareness and the utilization rates of financial tools such as ABLE? What are the barriers, facilitators, and impact of financial planning? What are the sources of the information that these parents are receiving? And is there an association between demographics and the utilization of ABLE accounts? I used a cross-sectional study design using convenience and snowball sampling, and I was able to recruit 176 parents of children with intellectual and developmental disabilities between the ages of 0 to 26 years old. These parents completed an online survey that was available in both Spanish and English. And if they chose to, they could provide an email address to receive a $10 Amazon gift card. Quantitative data was analyzed using SPSS, and qualitative data was analyzed using reflexive thematic analysis. So of the 176 parents who completed the survey, most were mothers and resided in Florida and were white and non-Hispanic. Almost a third of the sample made an annual income of $50,000 to $75,000. 31% said that they had little money left over at the end of the month, and 27% said that they were just meeting basic expenses. The most common disability type among the participants and the children was Down syndrome and autism spectrum disorder, with almost 44% of the children receiving Medicaid. Among these parents, 40% were not confident in managing their money. Almost 95% wanted to secure their child's financial future. Over 70% had thought about securing their future between them being born and them being 5 years old. And almost 80% had thought about how to secure their child's financial future. But it's very important to note that only 50% of these parents actually had a specific plan in place. Almost 90% were worried, stressed, or anxious about their child's financial future. Now, when you look at this chart, one of my research questions addressed the awareness of these different types of financial accounts. So over here, we see that 57% of my participants had heard of the ABLE account, compared to 93% that had heard of either a checking, savings, trust accounts, or stock investment options. I also want to draw attention to 3 different groups that I created in my study for the purposes of analysis for later. Now, group one were those families who had heard of an ABLE account and also had one for their child. Group two were those who had heard of the account but did not have one for their child. And group three were those who had not heard of the ABLE account. And the reason why I do this, as you will see in my later slides, is to break up the findings to understand how the different programmatic barriers and personal barriers affected the three groups, so that if we wanted to target making changes, we could in fact look at each group individually. In terms of utilization, it was apparent that utilization was really low. Less than 30% had an ABLE account for their child, 26% had a checking account. The highest of all of these was the savings account at 35%, and about 14% had a special needs trust for their child. Now, if you look at this slide, you'll see that I've color-coded the different groups like I described earlier for the ABLE account, and also for families who had a checking or savings account for their child. And I'll just point out the most common and most frequently cited programmatic barriers that these families shared in terms of opening or managing their accounts. First, what can money in the account be used for? What is the real benefit of having an ABLE account? Will the account affect SSI or SSDI benefits? What will happen to the money in the account in the event of death? And how much are the monthly fees for the account? And finally, will my child lose Medicaid benefits? Similarly, personal barriers that were cited by families among these four groups were not being sure that there would be enough money to contribute to the account. Now, as you can see, this was a concern that was shared by all four groups in my study, followed by concern about their own or their child's ability to make financial decisions, concern that they had not heard more about the ABLE program from other people or organizations, concern that they would not find someone to help answer questions as they tried to open an account, and finally, concerned that nobody else would contribute to their child's account. One of my other research questions of this study was the facilitators and the impact of having an account on the family and their child. So among families that had an ABLE account, they shared that it was easy to open and to manage, and they were most commonly using it for long-term savings and for emergency funds. Now, this is important because it shows that parents were saving towards the long term of their child, which is necessary given the fact that these children and these families have costs for healthcare across the lifespan. And the impact showed that it was extremely positive as parents felt more relieved and less stressed about having taken care of their child's future. Similarly, for parents who had a checking or savings account for their child, they also shared that it was easy to open and manage, and they were using it for long-term savings and independent living expenses. For children who were using a debit card for their checking or savings account, they exhibited more confidence in being able to manage their own money. And similar to the other group, mental health was better for parents who had planned and started to put aside money for their child in these accounts. However, these findings raise a few questions. If the accounts were so easy to open and to manage, then why are utilization rates so low? And perhaps these can be answered by the several programmatic and personal barriers that we just went over. The other thing that we want to contemplate is that we know that the ABLE account can be used for many other expenses besides using it for long-term savings and an emergency fund. So perhaps it is important to raise awareness to families who do have ABLE accounts to be able to use the account for other purposes besides just savings. The final research question was, what was the association between demographics and ABLE utilization? Ethnicity was statistically significant, with race and age of the child being only marginally statistically significant. Now, for the sake of time, I'll just go over my qualitative findings really quickly. I identified 6 themes through the reflexive thematic analysis process, and themes 1 and 2 were barriers and facilitators to opening financial accounts. 3 and 4 were barriers and facilitators to managing financial accounts. Theme 5 were recommendations for the ABLE program that parents made. And theme 6 described the impact that financial accounts had on both the parent and the child. Now, just to capture a few of the quotes that kind of stood out in my study, in terms of barrier, one parent shared, "My child is young now, and I don't see much benefit to opening an ABLE account. It might be tax-free, but if the interest is a typical savings rate of less than 1%, it wouldn't make much difference anyway." Another barrier that parents shared was, "We hope to get ourselves to a point where we can open and grow an ABLE account, but our financial situation is such that we don't have the money to do so." On a positive note, one of the impacts of having an ABLE account was, "I feel as a mom, I am more relieved that this ABLE account can help with my son's life. He needed a hearing aid that insurance or even agencies won't help acquire. Because he has the ABLE United account, he was able to save and buy his own hearing aid, which made us all happier. Thank you." So in terms of recommendations for the study, from my study, I broke it up between two different groups, SSA and the ABLE programs. So first, with the SSA, I would actively encourage enrollment in ABLE and other SSA programs, and for the SSA to collaborate with banks, financial planners, and disability organizations to disseminate this accurate and timely information. I would also recommend financial consultations and workshops as an automatic benefit to families of beneficiaries within the SSA system. I would also recommend embedding money management skills within programs like PASS. And I would, of course, in the long term, recommend increasing the monthly maximum payments so that families are not living within the $2,000 income. In terms of recommendations for the ABLE program, I would suggest improving awareness and clarity about the ABLE criteria and program components, offering prepaid debit cards, and enhancing support and guidance for the families, such as providing support with filling out tax forms and how to undertake withdrawals. And also in the long term, thinking about increasing contribution limits for the families. The strengths of the study was that it was the first of its kind exploratory study looking at the ABLE program and other financial planning efforts using both qualitative and quantitative data among families of children with IDD. However, it is a cross-sectional survey with a small sample size, which means that generalizability is limited. And there is also the risk of social desirability and volunteer bias. My final takeaway from this entire study is that it is clear that utilization of accounts among this group of families with children with IDD is low, but it is also evident that the impact it can have on both the parent and the child is positive. We found many barriers, but some of them can be addressed very easily and quickly through just better information being shared across the board. But there were also other barriers that cannot be so quickly addressed and that need to be really considered in terms of long-term policy considerations. And that is my study. I want to thank you, ARDRAW, SSA, and PRI, and especially Erica, Laura, and Kristen for their monthly calls and support via email. My mentor, Dr. Burke, without who I couldn't have done the study. I also want to acknowledge John Finch, who is the director of United here in Florida, who really helped me with recruitment and understanding the ABLE program when I was starting to develop my idea. And of course, I want to thank FIU Embrace as well. Thank you.
Thank you so much, Rumi. That was wonderful. So I'll open the floor for questions for Rumi. Looks like we have a question from Dalton. Go ahead, Dalton.
Hi, Rumi. Thank you so much for your talk. And you're totally right. Our topics are so united with one another. You're studying the parents and I'm studying the other half of that. And I really like that complementary piece. Where do you look to, go with this research? Are you going to continue this line of research? And how do you, see this combination of problems with ABLE accounts? Is it going to affect SSA? Is it going to affect benefits long-term? How is that going to play out? And what would the approach then be to disseminate better, higher quality information to families? Thank you so much for your talk.
No, thank you for your comment, Dalton. I appreciate it. Yeah, I'm glad you see how our studies complemented each other there as well. I really think that one of the nice things about my study was that it looked at both the programmatic side and the personal side. So like I pointed out, there are some things that can be very quickly addressed just in terms of the messaging and the clarity of the information that's being sent out. While there are other more important, more, deeper things like not having enough money, which is what parents keep sharing as a major concern, which obviously comes down to the root cause of, the poverty and just not having that enough income. So I think there are two sides of this. And in terms of just, improving the information that gets sent out and clarity, a lot of my parents, and because of time, I didn't go into the depth of the findings that I had, but a lot of the parents were just simply not using their account because they didn't know how to make withdrawals. And they were worried about the complications it would cause with completing out tax forms. And, so it shows that there's this big barrier with just not knowing. They've created this account, but they just don't know how to make the most of it. So perhaps just increasing that awareness. And the parents shared that they would love to have a recorded webinar. They would love to hear more people talk about the ABLE program that, they haven't heard so many people talk about yet. And, as I've learned in my few years of working in disability research is that, a lot of the recommendations that parents take on are the ones they hear from other people and other families in similar situations. And if you don't have that happening actively, parents are going to hesitate moving forward. So that's what I see moving forward. I don't know if I answered your question, Dalton, but thank you.
Yeah, no, thank you so much. I'm excited to see this published or whatever you plan to do with it. It's excellent research.
Thank you. Thank you.
Thank you both. And Rumi, some of that really kind of overlaps with some of what Michelle was talking about in her presentation yesterday. So I know you guys have some overlap there. If anyone is interested, all the students' papers will be posted online on the ARDRAW website, as well as all the webinars if you want to go back and catch one. I just have a clarity question about your demographics, Rumi. Can you just talk more about the 84% of your participants were from Florida, and so that other 16%, do they come from neighboring states or?
Yes, they were actually from across the country. There were some all the way in California, Seattle. What's the name of that state? The one underneath Washington. I can't remember it for right now.
Oregon?
Yes, thank you. Yes, so there were some from that. I think it really just came from the convenience and the snowball sampling. And a large part of the ones that were from Florida was thanks to John Finch, who's on here. Thank you for being here, John. With his efforts and just through the organizations that really took it forward to kind of send out my recruitment email to their organizations. So a large reason why I have a lot of people with Down syndrome in my study was because the Down syndrome organization of Florida really sent that survey out to all of its email list. So.
Thanks, Rumi.
Thank you.
Any other questions for Rumi? Any questions for anyone else? Anyone else who has presented today? I'll encourage you all to join. We've got two final webinars in this series, both tomorrow and the day after, and we would love to have you at those webinars as well. And we're certainly looking forward to it. If you do have any questions for any of the students who presented today or any questions about the ARDRAW program in general, feel free to hop on the website or you can email me at ardraw@prainc.com. Got someone in the chat here. Just congratulations. So, all right, well, great job, everyone. And thank you so much for joining us today. And hopefully we'll see you all in the next few presentations. So take care.
Thank you.